Good afternoon, everyone. This is our lecture on the physical examination of the head and neck. Take note this is part of the larger examination of the head, eyes, ears, nose, and throat, also known as AGENT. However, for the purposes of our lecture, for it to be manageable, we have divided um, this lecture between the head and neck, eyes and oral cavity, and the ears and nose. Our references for this, of course, are dates, the complete guide, and the pocket guide, as well as the visual guide. Many of the critical structures like sensory organs, cranial nerves, and major blood vessels originate in the head and neck. Take note, however, that although we have separated the lectures, actually they are done at the same time. So their structures and function are linked. And in practice, actually, um, most of the examination is done by ORLs, or orthorhinolaryngologists. Um, Under them, before was ophthalmology. However, it has since separated into its own subspecialty. Here are the common and concerning symptoms during the health history. So for headache, we're going to discuss it today. For changes in vision, we have a separate lecture on the eyes and oral cavity, as well as with eye pain and double vision. Hearing loss, dizziness, we're going to discuss it in our ear lecture. Nosebleed with our nose lecture. And for this, we're going to tackle them today. When many of the symptoms are benign, careful attention to the interview and examination can distinguish common concerning serious underlying disease. One of the most common symptoms we encounter in clinical practice is headache. Headache could be primary or secondary. Primary just means there is no other underlying cause, while secondary means there is a different underlying cause. It could be infectious in the case of meningitis, or it could be vascular in the case of subarachnoid hemorrhage. Examples of primary headaches include migraine, tension, cluster, and chronic daily headaches. As you can see, all of them tend to be chronic as well as episodic. Right? Next, um, what are some of the things you need to ask to clarify what type of headache it is? Is it unilateral or bilateral? If it's unilateral, it could be migraine. Also, if it's tension type, it's like a band over the temporal area. If it's cluster headache, it's like an ice pick in the retroorbital area. Next, you need to ask, is it sudden onset like a thunderclap? For this, you need to rule out important considerations, especially life-threatening diagnosis, such as subarachnoid hemorrhage, as well as meningitis. Next, you ask, is it steady or throbbing? Is there an aura? These are associated symptoms that surround the headache. So, for example, in migraine. Next, you ask the severity. The pharmacologic pattern, as I have mentioned, episodic disease, episodic headache tends to be primary, as well as associated symptoms. For example, in acute sinusitis, it tends to worsen with Valsalva maneuver, as well as with leaning forward. And of course, we need to clarify the area, specific area of pain. So I mentioned tension type headache, like a band. Retroorbital pain, parang ice pick na tinutusok, clustered headache. So here are some red flags or warning signs of more severe diagnosis when it comes to headache. First, if it's progressively frequent, it's becoming more frequent over a 3-month period, or it's becoming more severe. Next, it's sudden onset like a thunderclap or the worst headache of my life. It tends to be subarachnoid hemorrhage. New onset after age 50 years because it can be related to cancer. Next, aggravated or relieved by change in position because it could be sinusitis, especially when you lean forward. Um, Acute sinusitis could also be precipitated by Valsalva maneuver. There could be associated symptoms of fever, night sweats, or weight loss. This could be many things. In the Philippines, it could be tuberculosis. It's also known as the symptoms of certain hematologic cancers, like leukemia and lymphoma. Of course, if there's cancer, HIV infection, or pregnancy. especially for instances an immunocompromised condition. Next, you should also check if there's a recent head trauma because it could be hemorrhage. Also note if there's a change in pattern from past headaches and a lack of similar headache in the past, meaning it's new onset. And lastly, of course, if there's any associated papilledema, neck stiffness, and any focal neurologic deficits. This would suggest that there is a lesion somewhere in the cranium. Now here I'm discussing the three primary headaches that you need to know. These are the most common ones you're going to encounter during your rotations. Tension, migraine, and cluster. Tension type headache is the most common type. You've probably experienced this before, usually at the end of a long day, okay, or if you're dehydrated. Where do you feel it? It's bilateral, at the back of the head, or frontotemporal. It's like a band. And the feeling is pressing, tightening, and non-throbbing is steady. It's gradual in onset, and it can be triggered by either muscle tension or stress. It lasts from around 30 minutes to 7 days. In contrast, migraine headache tends to be unilateral, around 70%, and the feeling is throbbing and is more severe. It's rapid in onset, having a peak of 1 to 2 hours, and it lasts for a long time, for around 4 to 72 hours. Also, there's aura. So, the associated symptoms could be nausea, vomiting, and photophobia. So, there are triggers as well, but it's not just muscle tension or stress. It could be alcohol, food, stress, and noises. Okay? And lastly, we have cluster headache. Cluster headache is felt behind the eye, or it could be around the eye, and tends to be unilateral as well. Take note, tension here is bilateral, and the other two are unilateral. Also, the feeling of cluster headache is sharp. Like as I mentioned earlier, parang ice pick at pinto sa kamata. It's abrupt in onset and peaks in minutes. And because it's called cluster headache, it's called cluster headache because it comes in clusters. Also, there are other autonomic symptoms. And autonomic meaning the autonomic system is activated, but it's just unilateral, meaning there may be tearing or run nose on that side. Okay? It will be triggered by alcohol. Next, let's look at common complaints in the neck. One of the important things we're going to learn in medical school is the difference between an upper respiratory tract infection versus a lower respiratory tract infection. Of course, lower respiratory tract infections are more worrisome because it's deeper in your system, right? Like tuberculosis or pneumonia. And one of the important things that you have to remember is that with lower respiratory tract infections, you have lung findings. But of course, with upper respiratory tract infections, you don't need any of those. We're going to learn more about that later on. Upper respiratory tract infections also need to be classified between bacterial and viral. You get to know whether you're going to prescribe antibiotics, right? So previously, we rely on clinical prediction rules. But now, um, international guidelines recommend rapid antigen testing as well as throat culture. Okay? Um, so one of the more common upper respiratory tract infections is just sore throat or pharyngitis. And sometimes pharyngitis comes with swollen lymph nodes. Okay? So our reference encourages the use of the term swollen glands with patients because lymph nodes tend to be um, jargon, medical jargon. However, for the Philippines, we could use the common term tulani. Most of us know that. Okay? What are some other complaints? There could be bleeding gums, and they are commonly caused by gingivitis. So for this, of course, need the help of your dentist. Okay? Hoarseness may sometimes be worrisome, but hoarseness is just any change in voice quality. There are some acute causes. For example, voice overuse, common among teachers, as well as barkers, or it could be viral laryngitis. But if it lasts over 2 weeks, you need to do laryngoscopy. In other words, you need to visualize the larynx. Later, we're going to learn how to do that. Why? Because we need to rule out any hypothyroidism, mood loss, nodules, or even cancer. Okay? So vocal cord nodules are um, are also seen among voice abusers, like teachers. Lastly, we have um, complaints for goiter and thyroid function. Goiter just means an enlarged thyroid gland is here, at the here of the neck. And there are two types of symptoms you need to know. Hyperthyroidism, in which you have an excess of the thyroid hormone, and hypothyroidism, in which you have a lack of it. So with hyperthyroidism, your metabolism increases. Because of that, you generate more heat. Therefore, you have heat intolerance. Then from that, you have weight loss. So you may have palpitations, fast heart rate, as well as moist skin. So for hypothyroidism, you just have the opposite symptoms. You have cold intolerance, weight gain, dry skin, as well as slowed heart rate. Before we proceed, let's quickly review the anatomy of the head. So the regions of the head are named after the underlying bones. You have frontal bone, parietal bone, temporal bone, and occipital bone. Okay? So these are the regions as well. Frontal, parietal, temporal, and occipital. So you have the salivary glands. Okay? The parotid gland is here, superficial to the mandible. So remember, the facial nerve goes in between that, the five branches of the facial nerve. The submandibular gland, on the other hand, lies deep to the mandible. It's here. And lastly, the superficial temporal artery could be palpated here, just anterior to the ear, specifically to the tragus of the ear. Okay, now what do you examine when you do a physical examination? So you check the hair. Is there a parasitic infection? Are there nicks? Ectoparasites? Next, you look at quantity, distribution, texture, and any pattern of hair loss. There are two patterns, right? Androgenic or male pattern and female pattern hair loss. Um, then you look at the scalp. You need to part the hair to look if there is any scaliness. The scaliness comes from various things. It could be seborrheic dermatitis or psoriasis. You could also look if there are any lumps or filar cysts, or even neval or lunar. For the skull, you can observe the size and contour. If it's enlarged, it could be hydrocephalus or something like Paget's disease. In the face, you can note the expression, contours, symmetry, and movement, and for the skin, you can observe the color, texture, and vision. And note that hirsutism or hairiness may be observed in persons with polycystic ovary syndrome because it's a problem arising from their hormones. Next, let's review the anatomy of the neck. Um, the sternocleidomastoid here, from your sternum here, your mastoid process here behind your ear, is this muscle. It divides each side of the neck into an anterior and posterior triangle. Next, the great vessels, which are the carotid artery and the internal jugular vein. These are deep to your sternocleidomastoid. So if you could see a vein here, that's the internal jugular vein. That's actually the external jugular vein. Okay? Next, there are midline structures. Uppermost is the hyoid bone, followed by the thyroid cartilage, followed by the cricoid cartilage, and then the tracheal rings. Now, in front of the second and fourth tracheal ring is the isthmus of the thyroid gland. The thyroid gland is here. That's why when you have a problem with your thyroid, it could manifest as goiter or an enlarged thyroid gland. The isthmus is this, the narrowing between the two lobes of the thyroid gland. It's located around the second to fourth tracheal rings, and the lateral lobes curve around the trachea. Now, kung nagkakapa ka ng kulani, saan ka magkakapa? Well, these are the locations of the lymph nodes of the neck. Submental, here, beneath your chin. Submandibular, to the side. Tonsillar, around here. Preauricular, meaning in front of your ears. Posterior auricular, meaning behind as you can see here, the external lymphatic drainage is separate from the internal lymphatic drainage. Of course, if you have an infection coming from inside the pharynx, then what will be affected is the internal lymphatic drainage. So how do we examine the neck? First, you palpate the lymph nodes. You palpate the lymph nodes using this, the pulse of your index and middle fingers. Don't use your thumb because there's a pulse there. So, what are you going to note? You note note the size, shape, and delimitation. Um, lymph nodes can be split, or if they are already coalescing together, it could appear as matted. Note also mobility. Does it move? And the consistency, is it hard, or firm, or soft? And lastly, tenderness. It is painful upon raising your um, examining finger. Okay? So there's a difference between pain and tenderness. Pain is direct pressure, while tenderness is upon moving your examining finger. So how do you note the consistency? You say around your forehead is hard, around your nose is firm, and around your lips is soft. Okay? So you have tender nodes, it suggests inflammation for whatever reason. It could be infection, and if there are harder fixed nodes, these are more worrisome because they suggest malignancy, cancer. Okay? And of special note is an enlarged supraclavicular node here on the left. This is called Virchow node. Okay? Now, when the Virchow node is enlarged and painful, it's called the Toisier sign. Okay? And this is worrisome because it suggests a possible thoracic or abdominal malignancy, such as lung cancer or ovarian cancer or stomach cancer. Okay? Because some cancers have a tendency or a propensity to spread via the lymphatics, and they tend to lodge to the first lymphatic node. Okay? The first lymph node. Okay, how about for the trachea and thyroid? For this, you need to inspect and palpate for any deviation from the lead line. Because if there's a deviation away from the side of a lesion, then that means there is a growing lesion there, right? Growing lesion means it will deviate from midline, away from midline. Next, for thyroid inspection, you take the patient's head back. Also, you use tangential lighting, and you ask the patient to swallow and watch for upward movement. Okay? For palpation, you use a posterior approach, meaning you stand behind the patient. Then you flex the neck forward slightly. You displaced the trachea to one side to complete the opposite lobe between the trachea and sternocleidomastoid. What are you feeling there? Are there any nodules? Is there any tenderness? Which happens with some form of inflammation. Of course, you need to note the size. Is it normal or enlarged? How about the shape? Is it asymmetric or not? And the consistency as well. Again, soft, firm, or hard. Now, if it's enlarged, it's goiter, right? Some you need to listen. You need to auscultate using your stethoscope. And sometimes you will hear a bluing. A bluing comes from turbulent blood flow. And a bluing is seen, thyroid bluing is seen when um, there is hyperthyroidism. Specifically, the condition known as Graves' disease. Okay? Now let's go to the types of thyroid dysfunction. It could be hyper or hypothyroidism. Okay, so we mentioned this, a goiter is just an enlarged thyroid gland. But you need to qualify it further. What kind of enlargement, right? So you need to know whether it's diffuse, meaning it's just enlarged everywhere. There are no palpable nodes. And it could be a single nodule or it could be multinodular. Because of course, later on we're going to learn that corresponds to different diagnoses. Okay? Thyroid function could be increased, decreased, or normal. If it's increased, it's hyperthyroidism. If it's decreased, it's hypothyroidism. I'm going to repeat the symptoms of hyperthyroidism. The bottom line here is fast metabolism. Okay? So the patient may appear nervous or anxious. They may be thin, or there may be unintended weight loss. There is heat intolerance. They feel warm or hot all the time. They may complain of palpitations. Bowel movements are more frequent as well. The skin is warm and moist to the touch. And there could be an enlargement of the eye or movement outwards of the eye. It's called exophthalmos. Sometimes the eyelids may be elevated, so there is scleral show, meaning the white of the eye is showing above the iris. So these conditions are suggestive of this disease. Heart rate is going to be faster than normal, and they may have tremors. Okay? Okay. So in contrast, hypothyroidism is just the exact opposite. So they have cold intolerance, they feel cold all the time, they will be constipated, they have dry, poor skin, and this condition called mixed edema. Mixed edema. Edema just means swelling, but this time it's a very specific type of swelling. This is not just fluid, it's also protein as well. So there's going to be swelling of the face, hands, and legs. Okay? How are we going to report the findings for the head and neck? So you could say the skull is monocephalic as opposed to hydrocephalic, right? Or whatever, macrocephalic. And you could also mention that it's axiomatic, meaning because we're involved in an accident, for example, or a car crash. Okay? You could note the hair. Is it thinning? Is it balding? Or is it just average texture? For the eyes, we're going to have a separate lecture. But let's mention it for now. You could note the visual acuity, the sclera, the cross-examination, the conjunctiva, the pupils examination. Are the pupils equal, round, or display reactive to light and accommodation? Or it is for the fundoscopy. Are the disc margins sharp? Are there no hemorrhages or exudates? With the ears, we're going to test the acuity, meaning can they hear well. Of course, we're going to visualize the tympanic membrane using your otoscope. Then, the tuning forks we're going to use for this test, like Weber. We use our bone conduction test as well. We use it for that. Okay? For the nose, we could examine the nasal mucosa, the septum, the throat. We can check the oral mucosa. And lastly, for the neck, of course, we have mentioned this. We're going to calculate the trachea, and is the neck supple. For example, in some cases of meningitis, it's not going to be supple. Okay? And of course, we're going to feel for